Hi, good morning, everyone. I hope everyone's Saturday is going well. Happy Saturday. I am Dr. Joy Evans, Dr. Joy Vina Evans, and that's Dr. Joy, PhD, not MD. And I always like to make sure, especially when I have an MD with us, I always like to try to make sure that I emphasize that I am not an MD. I have a PhD in public health. But I am so excited today to be here with Dr. Omari Young. This particular workshop, this particular event is sponsored by Advocating for My Uterus, which is a nonprofit organization that I created due to some issues that I actually had with uterine fibroids and due to the disparities that exist with women, especially Black women, centered around reproductive health. With that, Advocating for My Uterus has a goal of providing information to Black women and girls on reproductive health, rights, and justice at the local and national level, educating on strategies for preventing, maintaining, as well as restoring optimal health and wellness, specifically with reproductive issues such as uterine fibroids, polycystic ovarian syndrome, endometriosis. We're going to have conversations about menopause and so much more. And then to support and mobilize Black women and girls and women as a whole in support of equitable reproductive assistance, including healthcare, health disparities, contraception, access to menstrual products, as well as sex education. Today's event is for Polycystic Ovarian Syndrome Awareness Month. September is PCOS Awareness Month. And as such, I have Dr. Omari Young here today. I am so excited that Dr. Young is with me today, and we go way back to Hurley research days. I can't remember if you were a resident or a medical student at that point.
Medical student.
Okay. So when he was a medical student and I was working at research at Hurley Medical Center, that was our first time officially meeting each other. And so we've stayed connected since, and I'm so excited to know that he is back in Flint, Michigan, serving the community and serving those underrepresented that's in the city of Flint. So as such, let me just take an opportunity to go over Dr. Young's bio. I'm so excited again that he's here with us to share about polycystic ovarian syndrome. So Dr. Young is currently the program director for Hurley Medical Center Obstetrics and Gynecology residency program in Flint, Michigan. He is also assistant professor in the Department of Obstetrics and Gynecology at the Michigan State University College of Human Medicine. This goal was achieved through the foundation that was set by being a student athlete at Kalamazoo College. Following graduation in 2009, Dr. Young attended Howard University College of Medicine in Washington, D.C. He graduated in the top of his class and was inducted into the Alpha Omega Alpha Honor Medical Society. In 2013, he matched into the Harvard University Brigham and Women's Massachusetts General Hospital integrated residency in obstetrics and gynecology in Boston, Massachusetts. He has a strong interest in medical education, healthcare disparities, high-risk pregnancies, minimally invasive gynecologic surgery, uterine fibroids, and endometriosis. The strong desire to bring excellent women's health care to underserved communities brought him back home to Flint, Michigan. And so we are so excited to have Dr. Young here with us again. Dr. Young, I'm going to turn it over to you. Please know that Dr. Young does have a presentation he's going to share. If you have questions, please type the questions in the chat and we'll make sure that Dr. Young sees those questions. Dr. Young?
Good morning, everyone. Thank you for the wonderful introduction, Dr. Evans. I'm really privileged and excited to speak on this important topic, and I'm really amazed at the work you do with advocacy in reproductive health for women, and particularly African-American women, because we know the disparities that Black women encounter on a day-to-day basis in their regular lives, but importantly in my world in healthcare. So anytime I can be a part of events that can educate and empower Black women to understand their own healthcare and be able to make decisions that is informed in their best interest, I'm happy to be a part of it. So again, I appreciate it, and I'm very excited to be back home. It's been an amazing experience working in the city of Flint, where I'm from, and providing care for the women in the community that I grew up in and raised me into the man I am today. So I'm very excited I know it's a Saturday morning. The weather is still nice. So the layout, I'll try to use around 30 minutes to give a short presentation about PCOS and PCOS Awareness Month. And then I'll leave the second half for questions and answers because I know I'm going to let you guys get back to your regular lives. Weekends are precious, so I don't want to take too much time for your day-to-day lives. So with that being said, I'm going to share my screen. I'm going to give a short presentation on PCOS, and then I'll leave time for questions. Can you see my presentation okay?
Yes.
Perfect. All right, well, let me get started. So as Dr. Evans mentioned, this is September's PCOS Awareness Month. PCOS stands for Polycystic Ovary Syndrome or Polycystic Ovarian Syndrome. And I'm going to do my best to give a general overview, but also I'm going to try to cater my talk on how it specifically can cater to and support Black women who suspect or already know they have this diagnosis. Again, I'm Dr. Young, and I'm an OBGYN here at Hurley Medical Center. Unfortunately, I don't have any relevant financial or non-financial relationships with this presentation. I'm just happy to serve the women in our community and abroad. So I'm just going to be speaking not for any financial gain. As Dr. Evans mentioned, I have two roles in my job. I'm a clinician, I'm a surgeon. That is my true passion and my calling, but also I have a passion for medical education, and that brought me into my role as the program director. So I train physicians in training who are pursuing a career in obstetrics and gynecology, and also I educate and train medical students who attend the Flint campus for Michigan State University College of Human Medicine. I'm a proud Howard grad for medical school, and as Dr. Evans mentioned, I did my residency training in Boston. I finished in 2017, and I've been at Hurley since then. And it's been an amazing 5 years. Actually, September 1st was my 5-year work anniversary of being at Hurley. So a few objectives. First, I want to let you know what is PCOS. So we're going to give a clear definition of what PCOS is. We're going to define how women commonly present with PCOS, and particularly how Black women may differ in their presentation to the physician's office. We're going to identify the diagnostic criteria for PCOS. We're going to identify long-term health implications of PCOS. We're going to briefly discuss PCOS impact on fertility and PCOS's impact on pregnancy. And then lastly, we're going to wrap it up with identifying current treatment and management options for PCOS. But overall, through all the information I give you in this next half hour, I want the number one piece I want to take from this is, one, I want you to feel well informed on PCOS. I want you to feel empowered. And then with that information, when you present to your primary care doctor, when you present to your family physician, when you present to your OBGYN, you can advocate for yourself so you can get the best quality care when you have the diagnosis of PCOS. So that is my number one goal at the end of this presentation and at the end of our question and answer. Throughout the presentation, feel free to stop me, raise your hand, use the different reactions that Zoom allows, and I can stop and clarify anything. And then also you can use the chat to field any questions. And then at the end of my presentation, during the Q&A, I'll try to get through as many of the questions as possible. So why is PCOS Awareness Month a big deal? So why is this diagnosis devoted a whole month of September? Because it is an important diagnosis. So syndromes in general mean that it's a combination of multiple diagnoses. So commonly, most people know what high blood pressure is, you know what diabetes is, those are common medical conditions. Well, syndrome encompasses multiple medical conditions that come together and they create a syndrome. And the reason why PCOS is so important is because it impacts women's reproductive years. So from their teenage years all the way to their menopause and beyond. So it's a chronic medical condition that can impact a woman at different stages of their lives with significant long-term health implications. So that's why it's such an important syndrome to understand, and that's why Awareness Month was devoted to it. So specifically, it's an endocrine or hormonal disorder. And as I get into the presentation more, I'll give a little bit more background on why it's a hormonal disorder. But ultimately, when you think about what makes a man look like a man and what makes a woman look like a woman, it's the representation of the male hormones, which are what we consider steroids or androgens or testosterone, and then our female hormones, which are estrogen and progesterone, and those are the common hormones that we see in birth control pills. So PCOS develops when there's an imbalance between those male hormones and those female hormones. So when there are high level of male hormones, then you start seeing manifestations of PCOS. And the three most common components to PCOS, with this imbalance in more male hormones, you get missed or irregular menstrual cycles, number one. Number two, with these high level of androgens or male hormones, you get male pattern hair growth. So you might not quite have a beard like me, but you'll notice that, oh, I'm starting to see more hair on my chin, hair on my neck, my back. You might start seeing some balding that you didn't previously see. So any kind of male pattern hair growth. And then number three, hence the name, polycystic ovary syndrome. On ultrasound imaging, you can see an ovary that has a large number of cysts. So those three components, you don't have to have all three to be diagnosed with PCOS, but those are the three components that make up PCOS. So with that foundation of information, we're going to delve into some more details so you can, again, be well informed, empowered when you go to your next doctor's appointment, so you can really ask the right questions about the treatment and management. So who gets PCOS? So why me? Why am I experiencing these symptoms? Why am I having these signs? Is it something that I did wrong? Do I need to change my diet? Is it my family history? Unfortunately, like with many syndromes, there isn't a single reason or diagnosis of why women develop PCOS. But we know that around 5 to 10% of reproductive age women, so around from the ages of 15 to 45, 5 to 10% of the women in the general population develop PCOS. Not surprisingly, most women are diagnosed in their 20s to 30s because, again, more women are looking to get pregnant and start a family in their 20s to the 30s. So that's why it's more commonly diagnosed in the 20s to 30s. But in the case of the United States, with our obesity epidemic, we're seeing a lot more teenagers who are presenting with irregular menstrual cycles, with male pattern hair growth. So it's becoming more increasingly, even in my own practice, I'm starting to see more teenage women who are being diagnosed with PCOS. Interestingly, there is a similar prevalence between African American and Caucasian women, but it's a slight bump in Black women, around 4% for Caucasian women, about 8% of the population with African American women. But there are some ethnic differences in the presentation. So African American women are more likely to have associated obesity, more likely to have associated high blood pressure and heart disease. So again, like many disorders that Dr. Evans had mentioned, whether it be endometriosis, fibroids, infertility, and PCOS, the severity and presentation is more commonly more severe among African American women. So that's why the correct diagnosis and a timely diagnosis is so important for African American women, so we can get the desired outcome in treatment. So what causes PCOS? So again, we don't know the underlying cause of it, but we know that there are multiple genetic components, environmental components, and lifestyle components that come together that manifest in the symptoms of, again, as I mentioned before, 1, irregular menstrual cycles, 2, evidence of male pattern hair growth with the excess male hormones, and ultrasound findings of multiple cysts on the ovaries. So we know that they're commonly seen among twins, and we see an increased prevalence in women who have a first degree relative with PCOS, so a sister or mother. So there is some sort of genetic component, but we haven't found out the exact gene. We know there are risk factors. As I mentioned before, having a first degree relative with a history of PCOS puts you at a higher risk than the general population for PCOS. If you have a history of premature puberty, so early onset breast development, and other female sex characteristics at a young age, that puts you at a higher risk of PCOS. And as I mentioned earlier, with the obesity epidemic, early onset obesity during puberty put women at a higher risk of developing PCOS later in life. So what does PCOS look like? So this is the kind of prototypical. So when I'm giving a lecture to our medical students, when I'm giving a lecture to our residents, this is the most common kind of picture that you'll see in textbooks. You have an obese woman. She has male pattern facial hair growth. But again, as I said before, every woman presents differently. So this is one of the more common and prototypical presentations. But again, every single woman is different. You know your body, you know your health, you live with it every day. So again, even if a woman doesn't present with this quote unquote prototypical image of PCOS, you can still have that diagnosis. So common signs and symptoms, as I mentioned before, the top 3 that I have in bold. So irregular menstrual cycle, infertility, and that's a direct relation to the high levels of male hormones and the irregular menstrual cycles, male pattern hair growth and balding, severe acne, weight gain, darkening of skin, that's shown in the image. So you commonly see that in the creases of the neck, in the armpits, and then you can see skin tags. So you come to the office, you have one of these symptoms or all of the symptoms, you say, doctor, what is going on? So ultimately, our wheels are going to start spinning, and ultimately they're going to start their clinical evaluation. So the first thing we're going to do, we're going to get your full medical history. We're going to want to know if you have any pre-existing medical conditions. We want to know your pregnancy history, your sexual health history, your family history, because that's going to put everything into context. And then also we're going to do a full physical exam. So we're going to get your blood pressure, we're going to get your weight. We're going to observe you, see if there's any male pattern hair growth. Are there balding noted? We're going to do a pelvic exam because, again, with the high level of male hormones, with the pelvic exam, we might see an enlarged clitoris. We might see enlarged ovaries, which is a direct relation to the multiple cysts. And the imaging that I have up here, it shows a prototypical polycystic ovary. So that circular structure, that's the ovary. The white part in the middle, that's the normal ovary. And then all of these little dark circles are multiple polycysts around the ovary. So this is the prototypical, what we'll see on an ultrasound with polycystic ovary syndrome. And again, not all women will have these ultrasound findings, but this is when you have it, this is a commonly what we'll see on the ultrasound images. And then you're going to get multiple lab tests. You're going to get your testosterone level. So again, that's that male hormone. So we want to see if that's elevated, but then also we want to see your overall health. So we're going to get your thyroid level, we're going to get your glucose level, and we're going to get your cholesterol level, because we know that PCOS can impact you as far as blood pressure, cholesterol, and diabetes. So again, we're going to get a full comprehensive workup when you have that first visit with your physician. So when we do our history, physical, when we have that first visit, we get your ultrasound, we get all those lab tests. And once we have all that information collected, we're going to, as your physician, we're going to see, are you meeting the criteria? And again, this criteria is has a lot of flexibility and it's broad because, like I said, every woman that walks into the office is different and their presentation is going to be different. But ultimately, as I mentioned before, the three things that encompasses the diagnosis are high levels of your male hormone, irregular menstrual cycles, and then multiple cysts on your ovaries. You only need 2 out of the 3 to meet the diagnosis. And the other important aspect that I have in bold is that we want to consider other causes, because again, there are other pre-existing medical conditions that can mimic the same symptoms of irregular cycles of male pattern hair growth. So there are rare tumors that can secrete high levels of testosterone. In the age of athletics, it's not uncommon for female athletes to use steroid hormones to boost their performance or performance enhancing drugs. So again, that can produce male pattern hair growth and balding. And then also thyroid disease is a common medical condition that can cause irregular menstrual cycles. And then there are a few other rare conditions. But again, we want to, as your provider, we want to rule out those common things, and a lot of those laboratory tests that I mentioned in the previous slide can help us rule out those other causes so we're not going down the wrong pathway and incorrectly diagnosing you with PCOS when you might have another pre-existing condition that could be mimicking or presenting with the same symptoms. But again, to wrap it up in a nice bow, elevated male hormones, irregular menstrual cycles, and then multiple cysts on the ovaries. You only need 2 out of 3 to meet the diagnosis of PCOS. So there are long-term health implications. So one of the main things, and that's why I said that a lot of times many women commonly are diagnosed in their 20s to 30s, because a lot of times women present with the inability to get pregnant. And say, Dr. Young, I've been trying for a whole year. Me and my partner have a regular intercourse. We're not using condoms. I just don't understand why I haven't been able to get pregnant yet. So that's going to start again, get my wheels turning, and I'm going to again do my history and physical. And if there are signs and symptoms in lab work that are consistent with PCOS, then we need to start doing some workup to correct that. Other long-term implications, diabetes. So a large number of women with PCOS, they have what we call insulin resistance or glucose intolerance. So a lot of women with PCOS, and especially women who are obese, they have a higher risk of developing type 2 diabetes later in life. So again, diabetes, obesity, that's an epidemic within the United States. So, and then high blood pressure. Women with PCOS have an increased risk of high blood pressure. And we know that with elevated blood pressures, you have increased risk for heart failure, you're increased risk for stroke, you're increased risk for heart attacks. So again, PCOS is a serious condition that should be correctly diagnosed, because there are long-term implications that can affect your quality of life down the road. And metabolic syndrome, basically, that's a fancy term. So that basically says you have signs of bad cholesterol, you have signs of high blood pressure, and then you have signs of diabetes. So if you have those 3 signs, then there's concern, and then also obesity. So obesity, blood pressure issues, diabetes issues, and cholesterol issues, those are all related to metabolic syndrome. And again, metabolic syndrome puts you at increased risk for heart disease, so stroke, heart attack, heart failure. So important. And then again, related to obesity, sleep apnea. again, that's a chronic condition that can impact your lung health and your heart health. And as we can, not surprisingly, if you're having male pattern hair growth, you're having irregular cycles, you have a tough time getting pregnant, this is going to impact your quality of life. So it's not surprisingly, many studies have shown that many women with PCOS have higher rates of depression and anxiety. And a little known long-term complication is uterine cancer or endometrial cancer. And again, that's related to the irregular menstrual cycles. So if you have a long history of obesity and irregular menstrual cycles, that puts you at a higher risk of developing uterine cancer. So there's a whole host of health conditions that stem from poorly controlled PCOS or unrecognized or undiagnosed PCOS. So we know that the common things, which are, hey, I'm coming in and I'm trying to get my cycles in order. I'm trying to get rid of this facial hair. So those are the common things that women present with, but there are a whole host of other medical conditions as providers that we need to take care of and check for so that you're healthy for your entire life. So I'm going to take you to the classroom really quickly right now. So with infertility, so obviously every woman knows their menstrual cycle. You know, they like clockwork, but again, I'm going to give a quick overview so you can understand how it relates to PCOS. So the textbook diagnosis of infertility is the inability to successfully get pregnant after 12 months with unprotected intercourse. And this is for women that are under the age of 35. Women that are at the age of 35 or older, it's 6 months of regular intercourse with unprotected intercourse. And particularly, the reason why women with PCOS have difficulty getting pregnant is because they're not ovulating. So when you're not having a regular menstrual cycle on a month-to-month basis, it's more than likely that you're not ovulating. And ovulation happens in the middle of your menstrual cycle. So there are 3 phases to your cycle. So in the beginning, day 1, so the average menstrual cycle is 28 days. Day 1 is the start of your menstrual cycle. For some women, it lasts 4 to 5 days. Some women, it lasts 7 days. But that first part is your menstrual period. Then the next phase is what we call the follicular phase. And that's the lining of the uterus getting developed and preparing, because ultimately what your menstrual cycle is preparing your uterus for potential pregnancy. So as your female hormones with your estrogen and progesterone, they're at play in developing your uterus to potentially hold a pregnancy. And then also these hormones are acting on the ovary to ovulate at around day 14. So that's your ovulatory phase. So around day 14, your ovary should ovulate or release an egg that could potentially be fertilized by sperm. If you have these high levels of male hormones, they disrupt the normal activities of your female hormones, and you're not able to release that egg typically at day 14. And then also, when I mentioned uterine cancer, when you have this disruption in your normal hormones, you can see that the lining of the uterus is getting thicker and thicker. So women with PCOS, their lining, because they're not having a normal menstrual cycle, their lining of their uterus that they would typically shed on a month-to-month basis is getting thicker and thicker, and that puts women at an increased risk of uterine cancer down the road. So ultimately, women with PCOS are not able to get pregnant because when they're not having their regular cycles on a month-to-month basis, they're not ovulating or releasing that egg.
Excuse me, Dr. Young, we do have a question for you.
All right, go right ahead.
Okay, so one question from Brittany says, how much does stress impact a woman's diagnosis of polycystic ovarian syndrome?
That's a good point. So when I prefaced the diagnosis with PCOS, I mentioned that there are other chronic medical conditions that can mimic the same symptoms of PCOS. And stress is a common thing that can disrupt a woman's menstrual cycle. And stress and related to PCOS is kind of like that chicken or the egg. So is it the PCOS that's leading to stress, or stress related to PCOS? But again, with that depression and anxiety component that I mentioned, related to PCOS diagnosis, getting that adequately treated, because we know that stress can again impact your hormonal balance. So getting that appropriately checked, whether it be through medication or through therapy, that is an important piece to supporting women with the diagnosis of PCOS. So that is a great point.
Thank you. And then there's another question. Jasmine says, good morning and thank you for the presentation. You mentioned risk factors for PCOS.
Yes.
What are the protective factors that may help prevent PCOS? That she has two questions. That's number one. Are there any protective factors that may help prevent PCOS?
That's a great question, and I'll get to that, but I'll briefly answer that right now. So one of the common things that I talk to, just to kind of, since I'm on the pregnancy slide, the most common, the first thing I say to moms when they have their first visit with me for their either preconception counseling, or when they see me, when they say, hey, doctor, I'm looking to get pregnant, or when I'm seeing them for their first visit, is healthy mom usually leads to healthy pregnancy. Healthy pregnancy leads to healthy delivery and baby. So taking an appraisal of your health history, so getting regular evaluations and checkups with your primary care doctor, regular exercise, diet, weight control, those are the first line treatments for preventing and also managing PCOS. So that's cheap. And again, obviously it takes time and it takes work on your part, but that's the number one thing I tell all women who are dealing with PCOS. The number one things are the things that you can control on your own. So you can control your diet, you can control your exercise, and ultimately your weight. So those are preventive measures and also treatment measures for PCOS.
Thank you. And then the second was, if you have been diagnosed, what is advised to have the best outcomes, physical and mental?
And again, I would say the most important thing is to let your physician know what is the thing that is bothering you the most. I might have a woman that comes in with suspected PCOS and they say, I don't really care that I'm not having month-to-month cycles. It doesn't bother me, but I'm tired of the hair that's on my face. What can I do to address that? Or it might be a woman that says, hey, I'm looking to get pregnant. What can I do to get pregnant? So ultimately, my treatment is going to be based on how is this diagnosis impacting your quality of life? And then also, what is your specific goals of care? So is it, I want to get my cycles regulated, I want to get rid of this facial hair, or I'm trying to get pregnant, or I'm just trying to lose weight and just lead an overall healthy lifestyle. So when you come in to see your physician, you want to be very specific. If they don't elicit that information out of you, you want to be very upfront to say, hey, doctor, this is my diagnosis. This is what's bothering me the most. It's my cycles are getting on my nerves. I want to get it regulated. That's concerning me. Or, hey, this facial hair is bothering me. I want to address that. So ultimately, it's going to be catered around what's most important to you.
And then the last question here we have, is PCOS reversible? Once diagnosed, will you always have it in one way, shape, or form? In your presentation, you stated you only need 2 out of the 3 symptoms to be diagnosed. Yes. I was diagnosed over 15 years ago, but since then I've reversed my obesity, hypertension, the darkening of the circles have gone, my cycles have regulated and come like clockwork for years now. No longer pre-diabetic, but my last ultrasound showed multiple cysts still.
So that's a great point. So there's no established cure. There's only long-term treatment and management. So similar to if you were diagnosed with diabetes, if you were diagnosed with high blood pressure, if you were diagnosed with bad cholesterol, you'll start your treatment, whether it be lifestyle modifications, so diet, exercise, or if they start you on a blood pressure medication, if they start you on insulin, or whatever it may be, your symptoms improve, your labs improve, your quality of life improves, but you still have that diagnosis. It's just that it's been appropriately managed. So, because I think the unfortunate thing is that when you get that initial desired outcome, you kind of get complacent and then you stop doing the things that got you to that successful point. So unfortunately, there's no curative treatment for it, but it's ultimately it's long-term, consistent lifestyle modifications, and if medications are indicated to long-term medical management. So there's no quote unquote cure, but it can be definitely managed. And it sounds like you've been doing an amazing job at that.
Thank you. Those were the questions so far.
Awesome. So really quickly, because like I said, I told you I'm long-winded and I'm already going over my time. So PCOS in pregnancy. So women are at increased risk of developing diabetes in pregnancy, which is gestational diabetes. They're at increased risk of developing high blood pressure in pregnancy, which is gestational hypertension. And then women are at increased risk of developing preeclampsia, which is high blood pressure in pregnancy and protein in your urine. And with those risk factors, not surprisingly, women are more likely to be delivered prior to their due date and also preterm. Specifically, obese women who have PCOS have an increased risk of needing a cesarean delivery at the time of birth. And then, as I mentioned before, planning is the most important part. We know that most pregnancies are unplanned, but when you know that you have the diagnosis of PCOS and you're thinking about getting pregnant, you need to do an appraisal of where you're at in the diagnosis. What is your health status? You need to set up an appointment with your OBGYN, with your family doctor, with your certified nurse midwife right away. So again, so you can check your labs, you can check your blood pressure, you can get all those things in place. Because like I said, healthy mom leads to healthy pregnancy and more than likely a healthy delivery and baby. And that's again, the goal of that preconception counseling is to optimize any pre-existing conditions. And then one of the common myths too is that women who have been managed with metformin for fertility purposes when they have the diagnosis of PCOS, it's not, because a lot of times we get women who say, should I continue my metformin once I get pregnant? There has been no data that supports the routine use of metformin continued in pregnancy, unless you have the associated diagnosis of diabetes. So if you have PCOS, but also have been already diagnosed with diabetes and you're on metformin, you should definitely continue it. But if you haven't been diagnosed with diabetes, there's no reason to continue metformin once you're pregnant. So really quickly with treatment, like I mentioned, you want to establish your goals. So every woman's goals are different. So one woman might want to address their irregular periods. One woman might want to address the hair on their face, which is the medical term is hirsutism. They might want to address infertility, or they want to address their overall heart health. So depending on those goals, you want to have a conversation with your physician, and ultimately you want to have a shared decision making, so you have a treatment plan that you're ultimately comfortable with. You should never come out of your visit with your physician and not understand why they're ordering labs, why they're getting imaging, why they're starting you on a certain medication. So like I said before, I want you to feel informed, I want you to feel empowered, and I want you to be able to advocate for yourself when you go see your physician regarding this diagnosis or any diagnosis you may have. You always want to feel comfortable about the treatment plan that's been developed, and you want to feel like you play a role in that treatment plan. The days of the physician saying, do this, this, and that, and then you just follow their orders are over. It's a collective agreement on both sides. And as the question that was fielded earlier, what are some of the preventive measures and what are the initial treatment options? Again, lifestyle modifications. And unfortunately, when patients come into the office, they expect some magic pill that's just going to cure things day one. I think one of our goals as physicians is, again, managing expectations and letting you know that this is a chronic disease that's going to require long-term management and management of expectations on the timing of results. And one of the first line treatments is weight loss and lifestyle modifications. We know clearly that weight loss impacts all four of those. So weight loss has been shown to regulate cycles, reduce the appearance of facial hair, to, again, once you regulate a woman's cycle, then you can increase their fertility, and then also weight loss decreases your risk of developing high blood pressure, risk of heart disease, bad cholesterol, stroke, heart attack. So every OBGYN that you see, that's going to be their first recommendation: diet, exercise, weight loss. But specifically to each diagnosis, really quick. So with your irregular cycles, so you get your diet plan, you're starting to exercise, you're losing weight, but medical options that we can do to kind of balance the scales, because as I mentioned before, the underlying issue with this diagnosis is you have a lot more male hormones compared to your female hormones, and that's causing your cycles to be disrupted. So the first line medical management after lifestyle modifications is putting you on some sort of oral medication, hormonal medication, whether it be OCPs, which are the typical birth control pills that most women know about. And that can be a estrogen and progesterone pill, or it can be a single hormone pill, or it can be other types of like the depot shot, intrauterine device. They all have hormones that can correct that imbalance between the male hormones and the female hormones. And again, which option you choose is what you're comfortable with and what you might have used in the past. For the male pattern hair growth, there are medications that directly affect the levels of male hormones that are called anti-androgen therapy. So they decrease the levels of male hormone. Spironolactone is one of the more common medications, and then also birth control pills, again, can correct that imbalance between the male hormones and female hormones. And then obviously some women say, I don't mind doing the shaving, I don't mind doing the waxing. And then if you have the financial means, you can get laser hair removal. Regarding infertility, again, weight loss, correcting any pre-existing medical conditions, so diabetes, high blood pressure, correcting those will increase your fertility. And then, as I mentioned before, when I was giving that short lesson on ovulation, that's the underlying issue with not being able to get pregnant, is the inability to ovulate or release that egg. So there are some medications that we can do to induce your ovaries to release an egg. The only downside to those medications, they can release too many eggs. So sometimes with these medications, they can lead to multiple pregnancies. So women can have higher rates of twin pregnancy with these medications. These are medications that your OBGYN are more than capable of prescribing and putting you through. And then the kind of next step will be is IVF, or in vitro fertilization. And that is going to encompass seeing a specialist in infertility, which is a reproductive endocrinologist or REI physician. So that's how we address infertility. And then as far as your heart health, that's checking to see if you have diabetes, checking your blood pressures, getting an ultrasound of your heart, getting an EKG, those kind of basic, getting your cholesterol levels, so addressing those areas. So again, treatment is going to be catered to what's important to you and what we identify when we do our history and physical exam in the office and what your labs show. But ultimately, you want to come away from that visit feeling comfortable with that treatment plan and understand the implications of the treatment. But number one thing, lifestyle modifications will address all four of those. So key points, as I mentioned before, you just need 2 out of the 3. So evidence of high levels of male hormones. So that's either based on the labs that we test. So if you have high levels of testosterone, or if they're just clear evidence when we see in the office that you have male pattern hair growth, if you have irregular cycles, or when we do the ultrasound, you have multiple cysts on your ovaries. So if you have 2 out of those 3, you more than likely have that diagnosis. And again, every woman's presentation is different. Not every woman is going to have that prototypical obese male pattern hair growth. So again, every woman is presents differently, and the care should be individualized to that. It's again associated with lifelong conditions that impact the woman for their whole life. So obesity, infertility, high blood pressure, diabetes, heart disease. So there are significant health implications. They're having PCOS automatically puts you in the category for high risk pregnancy. So you want to get that appropriate planning before you attempt to conceive. And as I mentioned before, diet, exercise, weight loss is the #1 treatment plan for PCOS, and then hormonal therapy based on your specific goals of care. And obviously in the age of social media with Instagram, TikTok, you have all these influencers. And again, I love that women are advocating for themselves and putting their stories out. But again, you can get overwhelmed with information that might not always be correct or reliable. So #1 resource should be your provider. So talk to your physician first. But then your physician will give you some reputable, accurate websites to look up information for yourself, because again, that makes my job easier. I want my patients, when they come see me, and women that come see me, to feel comfortable and informed. I don't mind getting next challenging questions and putting me on the hot seat, because again, if my mother is getting care, my sister is getting care, my grandmother's getting care, I want them to know what they're getting into. I want them to know why they're taking medications. I want to know why they're getting these labs. I want them to know why they're getting these images. So the more informed you are, makes my job easier. So if you have a physician that's getting uncomfortable or defensive when you're advocating for yourself or asking questions, you might need to take a look and be like, maybe I need to see somebody else, because you should always feel comfortable asking questions. You shouldn't come away confused or questioning what's going on when you leave your visit. Again, thank you so much. I know I apologize again. I know I'm long-winded. I went over my time, but it was a lot of information to share, and I tried to be as concise but also comprehensive, and kind of give a general overview of what I'm thinking as a physician, and also kind of clinical pearls and kind of things that you can take away when you go see your physician. If you think that you have PCOS, or if you've already been diagnosed and you feel like your treatment hasn't met your goals. So I'm going to stop sharing my screen and we can take some questions.
Thank you so much, Dr. Young. This was amazing, amazing information. There are some questions in the chat. Is there a certain diet that works best with PCOS to help with weight loss?
So that's interesting. So, and that's why I love working in Flint, because we have a very diverse patient population. Obviously, we have a large African-American population, but we have Hispanic, we have Indian. I mean, we have a full spectrum of patients with different ethnicities, different cultural backgrounds, so that when I'm teaching our residents and medical students, not everybody has access to the same quality of food. So ultimately, you should have a delve into, and again, that takes more work on our part, but you need to understand what your patient has available to them, and then also what's culturally within their diet. A woman that's eating fried chicken, greens, and all the prototypical soul food is not going to automatically do a 180 and start eating a kale salad. So you have to set, again, realistic goals and expectations. So one thing is just to say, what's your amount of food are you eating? So how often are you eating? What's the amount you're eating? So one of the things I say is just, let's try to just do something in more moderation, drink more water, exercise. And then as we start building up and getting more confidence, I think the worst thing you can do is put too much on someone's plate. They get discouraged and then they just relapse and go back. So, and again, our care is multidisciplinary. So we'll hook you up with a dietitian or a nutritionist. And again, so they can have that more detailed conversation of what's your day-to-day diet like. So get a food diary. What am I doing in the morning? What am I doing in the afternoon? Am I snacking in the middle of the day that I'm not necessarily accounting for because I don't think about it? I'm eating a bag of Skittles in the office and I was like, I forgot to do that a few times a day. So really taking into account. So there's no cookie cutter keto diet or this specific diet. Again, it's individualized to you, but ultimately high protein, diet and low fat diet, you should have carbs. Carbs are essential, especially if you're exercising, because there's your energy source. So you have to have some level of carbs. So those no carb diets aren't realistic. I'm a runner, and I have to have a certain level of carbs just to do my day-to-day activities and have that minimal caloric intake.
Thank you. Another question is, can PCOS be misdiagnosed as premenopausal?
Yes. So when you have those irregular cycles, so the average age of menopause in the United States for women is around 50 to 51 years of age, but a lot of times I cater it to the woman's health history. So I'll ask a woman, so what's the kind of average age of the women in your family? When do they stop having their periods, or when they start telling you that they're having hot flashes? So some women say, hey, my mom or my granny says she stopped having her periods at 45, she stopped having at 47, whatever it may be. So I try to individualize it, but the average age is 50 to 51. But that 45 to 50 range, that's what we call perimenopause. So that's when your cycles stop going from month to month to, like, I get it every 2 months to every 3 months. It's starting to get more irregular. So that can be commonly misdiagnosed as just being perimenopausal, instead of doing the full workup and saying that it's PCOS. So when we do those lab workup, we can get your female hormone levels that your ovaries produce. And if those levels are significantly low, then that'll give us an idea that you're probably moving towards menopause, and not necessarily PCOS. So again, when we do our workup, we always want to exclude other common causes of the irregular cycles.
Thank you. And then I see Tanika says, good morning and thank you for this presentation. I'm a textbook version of this. I'm a health provider myself, and I was the one who came to my providers and OB concerning this because of the abnormal cycles and facial hair. From progesterone for 7 days, being referred to IUD, I'm concerned because I'm having trouble losing weight. Right now, my weight is steady, but I can't lose. I walk, I don't eat bad. If you like, you can use me as a case. Things that have helped me are magnesium. I'm just lost as a healthcare professional. I feel like I'm just treating symptoms. All my levels are good with meds, but I hate meds. And then just sorry, long post, signed an obese PCOS sufferer.
I think, and again, I think one of the things that has opened my eyes up as I've been in practice is that you go through, as physicians, we go through our training, we go through schooling, and we have those things that we check off. But again, once you get into practice, you realize some things you just have to throw out the window. And then also, I've been able to humble myself and keep an open mind. I think I'm always open to my patients saying, I want to try a holistic approach. I'm going to try some supplements, some sort of herbal medicine. And if I can confirm that it's not going to do any harm, I say, hey, why not? We've exhausted all our normal means. And again, I think specific to you is identifying what specific outcome that you want. Is it, I'm just having trouble losing weight, or is it I'm having trouble getting my cycles? I think with the weight thing too, and I didn't mention it before, is that sometimes we get to a point that we've exhausted all our conservative measures, meaning diet, exercise, some medications that kind of suppress your diet, and then have to get a referral to a nutritionist and a referral to a bariatric surgeon. So those are some of the common measures that I've seen in patients of my own with PCOS. And again, I think it's managing expectations. Everybody's timeline is different. Some women will start seeing changes and improvements earlier than others. And like I said before, there's no cure. It's a lifelong syndrome that you have to manage, and everyone's timeline and response to treatment is different.
Thank you. Thank you again, Dr. Young. If we can make sure that we give Dr. Young an amazing virtual round of applause. I see Jasmine Hall says, I love that support is provided for clients to help make those lifestyle changes. I do want to reiterate something that you said, Dr. Young, is, and what I kept hearing throughout the entire presentation. I think Jasmine Hall, myself, Kiera Evans, all of us are public health, right? And so one of the things we know is, and what we do in public health is from the standpoint of the disparity as it pertains to food, as it pertains to socioeconomic status, as it pertains to the social determinants of health, or specifically the grocery stores. So in some areas, we know that there's a huge issue, especially with the city of Flint. You know, there's certain areas, there's a grocery store in the city, you know, proper or whatever. And so therefore, some people have issues obtaining fresh fruit.
Yes.
Some things that are common to us is not common to everyone. Some things that we are privileged to be able to go to Whole Foods. Everyone doesn't have that privilege because of the cost, but also because of the location and the access. But one thing that I kept hearing you talking about was the importance of diet and nutrition, but also exercise as well. And so really, when we think about a lot of health issues, whether it's obesity, blood pressure, migraines, whatever it is, or these reproductive women issues, sometimes we see at the forefront is the diet, exercise, and also the mental health component as well.
Yep.
So, ladies, I do want to say this to each and every one of you. Please make sure that you're taking care of your mental health. If you need to start speaking with an actual therapist, please go ahead and talk with a therapist. It does not make you crazy. It makes you wise to say, you know what, I need to talk some things through. I'm feeling depressed. I'm feeling sad. And especially with these diagnoses, we can feel alone. We can feel sad. We can feel depressed, not knowing what the future may mean as it pertains to children or, you know, whatever the case may be. So please also take care of your mental health as well. Dr. Young, again, I'm still seeing, even on Facebook, I see Dr. Brianna. Dr. Brianna said, amazing presentation. I see a lot of people here are saying the same thing. Thank you so much for the phenomenal information that you've presented. And again, just want to really thank you for that.
Thank you.
Absolutely. And then I do want to end with this. I want to thank the board. I see a couple of board members on here. Shanita Colbert is on the board of directors for Advocating for My Uterus. Thank you for your help and for everything that you do for the nonprofit, Shanita. And then Jasmine Hall is an advisor on the advisory board, and she is Flint's finest as well, MPH from Harvard. She know I always have to say that, MPH. And also a CMU chip as well. So Jasmine, thank you for that. And then we do have a giveaway. Jasmine Hall is providing a giveaway as it pertains to a free yoga session. Again, because we go back to that mental health and the importance of mindfulness, the importance of meditation, the importance of, again, making sure that we're in a good space physically, mentally, spiritually, in all aspects when we're dealing with certain conditions. I'm going to go back, see who the first person was who registered, and then you are the winner of this particular yoga session. So thank you, Jasmine Hall and her phenomenal organization. I am going to send you that information so that you can connect with Jasmine. And lastly, Dr. Young did leave his email address here.
Yes.
It is oyoung2, oyoung2@hurleymc.com. Thank you again, Dr. Young. Any last minute words you want to share?
Again, Dr. Evans, thank you again for inviting me to this wonderful event. I think awareness is a key word. I think, like you said before, a lot of times women are, and particularly African-American women, are suffering in silence, whether it be issues related to fertility, pregnancy loss, PCOS, endometriosis. These are very private. They're very vulnerable aspects of a woman's reproductive years. And a lot of these things are related to your femininity and what makes you a woman. So you feel embarrassed about having this diagnosis. But again, having this awareness a month, having these events allow women to fellowship, to understand that it's more common and it's very underreported, because again, not every woman feels comfortable to post on their Instagram, Facebook, and TikTok to say, hey, I have chin hair, I have a tough time to get pregnant. So again, these are very vulnerable and private things. So I think having these forums and events where women feel safe and comfortable to talk about this is so important. And again, it leads to better outcomes, because if it's diagnosed early and appropriately, you can get better outcomes.
Thank you. Thank you. And last but not least, please feel free to subscribe to the listserv at advocatingformyuterus.com, advocatingformyuterus.com. Next month is World Menopause Month, so we will be back with some information and an event on menopause as well as premenopause as well. Everyone have a wonderful Saturday. Dr. Young got his run in earlier today. I got my walk in, so I hope all of you.
Yeah, I practice what I preach. I'm running.
Right. So I hope all of you are able to get some exercise in today. Have a wonderful Saturday, everyone. And again, thank you so much, Dr. Young.
All right, have a blessed day, everyone.